Hi, welcome to Inside View. I'm your host, Sid Marsh, and today I have in the studio with me Dr. Eric Freedman, a urologist, and we're going to learn a lot about urology. Welcome, Doctor.
Hey, well, thank you for having me. Pleasure.
First off, tell me, what is the clinical definition of urology? How do you see it?
Well, urology, of course, by the term, it really comes from a Latin or Greek root, of urine, basically. So the urology is the surgical specialty that has everything to do, basically, with the production and excretion of urine. Now, in males, it also includes the sexual organs, which are closely tied into the urinary organs. But that's kind of a narrow field, and yet it's very, very broad in terms of all the kinds of problems that we deal with. So,
well, what got you into it?
Well, I think it has more to do with the kind of the personality of the people that you work with. So first off, as a surgeon, I mean, you have to like working with your hands and, building things and doing things and seeing a final project at the end of the day. So I think most people go into surgery because they like to, take care of a problem right then and there. And I got attracted to urology because, when you're a medical student, you rotate through all these different realms of medicine, whether it's pediatrics or psychiatry or neurology or different sorts of things. And when I was working with the urologists, there was two things that really struck me as being somewhat odd. Number one, the patients, generally speaking, were pretty happy, which is a bit unusual when you think of all the things a urologist can do to you. But they were really friendly and happy. They were happy to be there. And I think the main reason for that is because most of the time there was something the urologist could provide them to fix what their problem was. And then the second thing was that the urologists themselves were walking around pretty happy guys. They weren't stressed out. They were enjoying their work. They were more relaxed. They had a chance to sit down and talk to the patients. They didn't strike me as individuals who were really full of themselves. And so, I think like attracts like, and, those are the kind of individuals you could see yourself, working in that kind of situation. And that's really was the start of my attraction to urology. It's a very interesting mix of different types of surgeries.
Now, when you hear the term urology, you usually think of older people, men especially, but there's pediatrics, there's women, it's a very broad field, right?
Well, it's all of humanity, including those who are unborn. So I did specialized training in pediatric urology. I did a fellowship in Liverpool, England, after I finished my surgical training. And so in that case, there are people who are specific pediatric urologists who just look after mostly what are all the congenital abnormalities that humans can be born with. Other mammals, can have those kinds of similar problems. Veterinarians deal with some of those things too, but at least in terms of humans, the pediatric urologist is dealing both with girls and boys in terms of abnormalities that can occur. Anything from different kinds of blockages to intersex. Nowadays we hear more about that people are making choices in terms of their gender. You may not be born with the sexual apparatus that you actually think you should have. And so, that falls into the realm of that. There's all kinds of pediatric tumors, which are really heartbreaking. But nowadays we have so many different treatments that can, help these kids and save their lives. So that's just a small branch, which is pediatric urology. I mean, you're probably talking no more than 10% of all urologists, really, have any training or specialize to any degree in really pediatric urology. And then, of course, you talked about females. Well, in an average general urology practice, about a third of the patients are female. And you might say, well, they don't have prostates. Well, no, they don't, but they can still have all kinds of incontinence issues and urinary tract infections. Both men and women get kidney stones. Both men and women get tumors, from kidney tumors to bladder tumors. And of course, prostate cancer in men, as you know, is the number one most common cancer, but you probably didn't know that bladder cancer is number 5 and kidney cancer is number 7. So urology encompasses, way up there, a lot of different types of cancers that affect humans.
What is the number one problem you see in your practice?
Well, the number one reason why people in general, and of course that would be men because they make up the majority, are referred to urology practice is usually due to what's called BPH, which is the benign or non-cancerous enlargement of the prostate that unfortunately hits all of us as we get older, and some guys get hit with it when they're in their 50s. Some people maybe not until they're into their 80s, or some people are lucky enough to snake through life and never have a problem. But about 80% of men by the time they hit 80 certainly have some urinary problems secondary to prostate enlargement and the changes that brings to the body.
And what are some things they should watch out for? Go to your doctor when you feel
well,
this or see that.
and that's a very good question, because the data that's out there now would suggest that there's probably about 40 million men in this country who are affected with symptoms of what we call BPH, and I'll talk about those in a second.
What is BPH?
Well, I'll just circle back.
Okay.
Just for a second talk about the numbers. So they said there's about 40 million men who are actually affected with these symptoms. Only about a third of them are ever actually seen by a doctor, which is usually primary care doctor or internist, and a much smaller percentage of those actually get to see a urologist, for those kind of problems. So it's a tiny percentage of the population that I'm seeing. The symptoms that affect men as we get older, the common things would be, well, I'm starting to get up a whole bunch of times at night. When you were younger, you slept 8 hours or longer, and it never really bothered you. You can't hold your urine during the day. You're running to the bathroom more frequently during the day. More urgency, so you have a lot less warning time from the time you get the message to go until you better get going becomes much shorter. Those are just, you can have pain. It can be a very slow dribbling stream. Guys tell me sometimes, well, they have to go in the middle of the night. They have to sit down, and they can't even tell if there's a stream coming out. It's just so slow. It's just a dribble. They may feel like they're not emptying their bladder. And if you don't empty your bladder, you develop all kinds of secondary problems, such as bladder stones and urinary tract infections. You can even end up with permanent kidney damage, because there's, the things have to have a downward flow. So there's all these kinds of symptoms, and they're very, very common. And a lot of men, as these things start hitting them through life, they sort of feel like, well, I'm just getting older, this is what I should expect. Well, and that's not necessarily true. A lot of things can be warning signs of problems.
Now, what do you see as some of the keys to your success as a urologist?
Well, I think I'll take a step back from that question just for a second and just say, as a successful physician, because you train to be a doctor long before you get to be a urologist, but as a successful physician, you're not just, you have to know the anatomy and the physiology and all the problems and the medications, et cetera, so you have to have that kind of knowledge base, but you have to be able to relate to people. So that means you have to be a good listener, and you have to be able to get all the clues in your mind, or these little tidbits that you're getting. Might just be a little sentence, might be the way the patient's sitting, could be just little things, and you're piecing them together. So every patient who comes in, you're piecing together these little clues to try to come up with a working diagnosis, we would call it, of what the problem is. And then you have to come up with a plan of action, how you would want to either investigate it or fix it, and communicate that in a way that the patient can understand, because they didn't go to medical school. They're not going to understand all the jargon. So I think one of my strengths is the ability to communicate to people on a pretty level basis, where I'm not speaking above them or feeling like I am above them.
Now, how much time do you spend actually in surgery, and how much time do you spend in counseling and that sort of thing? Well,
I have a 1 day a week when I'm in the operating room, and that's typically a 10-hour day, although it can be longer. For instance, yesterday I was in the operating room from 7 o'clock in the morning till 9 o'clock at night, just basically going the whole time.
And how many different operations did you do?
That was 7 different procedures yesterday. There was an emergency at the end of the day. And so, you have to be relatively physically fit, just the stamina of doing that and the ability to concentrate and what you're doing. And you're not talking to the patient because they're asleep, but you have to communicate to the staff and make everybody understanding of what your goal is, because really that's what it is. You start off with a plan, and you hope you can finish it off and be successful. So that's 1 day a week, but then we do multiple other, what you'd classify as more minor surgeries in the office, and that goes on all day long. Anything from vasectomies to circumcisions in newborns to cystoscopies, which is kind of like people would understand what a colonoscopy is. So a cystoscopy is using a much smaller diameter flexible tube to actually look into people's bladders, through the urethra, and a variety of different procedures that stem off of that, prostate procedures and things like that we can do in the office. So my day is a real mix of seeing new patients and rechecking, recheck patients and doing procedures.
Now, is it different being a doctor in a rural community than being in a metropolitan community? Is urology different, or the services that are offered?
Yeah, I don't think it's really that different. There are general urologists, in the big city. I think the difference in the small city is that, you try to handle as much as you can, but you have to be aware of your limitations, either with yourself, your own surgical skills, or what your facility can offer. So there has to be those times where you're going to say to the patient, look, this is something really that needs to be handled, in the bigger center, and we're going to refer you on to Stockton or Stanford or wherever that is. And probably in the big city, I mean, if you lived in Palo Alto, that wouldn't happen. You'd be referring to yourself or, the guy who works in the office right beside you or that sort of thing. So that's probably one of the differences. But other than that, I think perhaps we can have a little bit of more relaxed pace and have a little bit more time chatting with the patients. At least that's what I see when I talk to patients who have moved here from the Bay Area or whatever, and they say, geez, medicine is really nice here. I can actually have a little bit extra time to talk to my doc.
Now, I've heard about this UroLift treatment.
Okay.
Can you explain a little bit more about that and what benefits it's all about?
Well, I guess it's one of the new and really exciting things. We talk about, what's the best thing since sliced bread? Well, when it comes to urology and the treatments of prostates, at least in terms of an office, kind of procedure, this is really a brand new thing. And so, again, just to take a step back, we mentioned that prostate problems are probably, one of the number one reasons why men get referred to the urologist in the first place. And the prostate is an organ that basically surrounds the urethra and sits right under the bladder. So if you just visually, if you imagine a wine bottle and there's the neck of the bottle, and let's say you had a cork in the bottom, well, imagine the cork is your prostate. And let's say the cork had a hole running through it so the wine could travel down through the bottle. But that cork over time kind of swells, and it not just squeezes against the bottle, it squeezes in on that channel and compresses it. So eventually that bottle's having a harder and harder time emptying out itself because it's traveling through a zone of higher resistance. And so that's basically what the prostate does. So the prostate over time, as it enlarges, doesn't just get bigger on the outside, it squeezes in on the urinary tract, it squeezes in on the urethra, and that pressure means that your bladder's working harder. And when your bladder works harder, if you imagine a weightlifter, he starts off as a little skinny guy and really loves lifting weights. So he's 16, and so by the time he's 25, he's a really big muscled guy. And he only got there from hard work. Your muscles have only one way to respond to work, and that's to get bigger and stronger. So if your bladder is working harder over the course of many, many years, at the beginning your prostate's not big, it's not causing any blockage, then the bladder wall itself, the bladder's a muscular pump, just like your heart. And the wall of the bladder actually starts to get thicker and thicker and thicker. Eventually it gets to the point where it just can't compensate with the pressure. It can't develop enough pressure to get the urine through the channel way, and this leads to all of these, other things that we talked about, the symptoms of enlarged prostate, retention of urine in the bladder, infections, and other sorts of things. So if you imagine that this enlargement of the prostate is really a simple mechanical problem, it's squeezing in on the urinary tract, the UroLift is a simple mechanical solution to essentially pull that open. And it's done with a very simple office procedure. It's an ingeniously designed little gizmo that we put up through the urethra. 3 biomedical engineers, developed this and worked on it for many years and really have it down pat. And now it's a procedure that I can offer in the office. The average guy is probably about 15 minutes, to actually. We put in these tiny little implants. They're almost, if you imagine, almost like little tiny staples that are holding the walls of the prostate open to enlarge the urethral channel, and the results have been pretty phenomenal, and usually in a very, very short period of time.
Now, is this something that's normally covered by insurance and that sort of thing?
Yeah, so and with all new procedures, it takes time for everybody to jump on board. Mm-hmm. It's being done in the United States now for 6 years, in Europe and Australia now for close to 10 years. So pretty much all the providers are covering it, except in California, the Blues. So Blue Cross Blue Shield seem to be dragging their heels, and that's only California. I think if you live in Nevada, Blues cover this. So for some reason, it's the Blues of California, but Medicare, Medi-Cal, United, TRICARE, military guys, so most of the other insurances now are covering this because they see this, number one, as a relatively cost savings for them. If they have to pay for someone to be on medication, tamsulosin, doxazosin, taurazocin, or finasteride. There's a whole bunch of medications that are used for BPH, and people are oftentimes on these.
We never heard what BPH is.
Oh, okay. So let's take. So BPH, just going back, is the benign enlargement of the prostate. So it's called benign prostate hyperplasia. Hyperplasia means growing, and it's benign means non-cancerous and the prostate. So that's what BPH is. In urology now, especially when we're talking about this UroLift procedure, I really try to get across to the patients kind of a new thing for BPH, because most men don't really have a good concept of their prostate. I mean, you don't feel your prostate unless it's injured or swollen or infected. It's not something that you're even aware is there. So the whole concept of, going in and your doctor says, well, you got a big prostate, this is a problem. That doesn't resonate with men. But if I say to you, I mean, everybody knows what your bladder is, because that's the thing that's talking to you all during the daytime. And if your bladder's not functioning well, if your bladder's the thing that's screaming at you all day and is running your life, people understand that. So if we say, hey, if we can do something to open up the prostate, and this is going to improve your bladder health or preserve your bladder health, that's something that's going to be very beneficial, not only now, but in your future life. So when I try to explain this to the patients, I say that BPH stands for bladder preservation health. So I'm kind of steering away from the prostate, because that's kind of sometimes goes over top of everybody's heads. But if you really drill down and say, I'm really concerned about your bladder health, because that's what's running your life, people seem to understand that, and that resonates a little bit easier with them.
And everybody's got a bladder, both women
and everybody's got a bladder.
women.
And what's interesting is that as this UroLift procedure has grown in popularity and patients have a good result, so they talk to other patients, we have women coming into the office saying, well, how can I get a UroLift? Well, no, you don't have a prostate, so this isn't designed for you. But it's very interesting how those kinds of things, grow in terms of, what people's wishes are.
Are there any other big advancements that are happening?
Well, in urology and in medicine in general, it's endless. And I would say, there's all kinds of, in surgery in particular, everything has become much more minimally invasive. So minimally invasive means trying to accomplish the same things through a smaller hole. And so with orthopedic surgery, arthroscopy, they can fix your shoulder just by making little, punctures, or your knee or your hips. Everything is getting much smaller with better quality equipment, and things seem to last longer. With general surgery, when they're doing bowel surgery now, a lot of times, you don't have the big old, cut. They're putting in these little probes inside, and you're having the same operation on the inside, but it's all done with, gizmos on the outside. Robotic surgery. So this is not that new now. The Da Vinci robots have been around now for 10 years, but it's really growing in terms of, basically more and more surgeons are being trained. And basically the nice thing about a robotic surgery, it's allowing the surgeon to sit at a console, a nice comfortable chair with cushy arms, looking at a big TV screen that's magnified 10 or 12 times with bright lights, and being able to control the arms of the robot with just using your hands. And so the robotic hands are very tiny, and they can do all the little they can do more swiveling than you can do with your wrist. And of course, your hands are pretty big structures, and when you're working inside the body, sometimes they're too big to get exactly where you are, and you can't see properly, and the light's not perfect. But with robotic surgery, you can get these tiny little hands into these tiny little places with very bright lights and magnified imaging, and so you can do very, very fine dissection, which means a lot less collateral damage to other structures around there, and recovery is just so much faster. If you can do it through little holes as opposed to a big slice, you're just going to recover faster. And so, in surgery in particular, that's been, one of the biggest advances. But I would say in medicine in general, when we look at the future, and the future is almost here, it's the understanding of genetics. So, people ask me in life, what's the best thing I can do for my health? And I tell them, choose your parents wisely. Now, obviously, you can't do that. But the reality of that situation is that if you have the right genes, you're going to live a healthy life and live a long life, probably no matter what you do. And we all know great-granddad who smoked 20 packs a day and lived to be 95. Well, why was that? Smoking obviously wasn't healthy for him, but he had the genes that allowed him to fight off all of the normal things that would occur to, an average sort of person. But we're going to have the ability very soon to have a much better understanding of cancer genes and aging genes and joint deterioration genes. So therefore, to be able to alter the whole process and be very specific in terms of how we treat people. So just to give you an example, nowadays if you have some kind of a cancer, you might go to see a medical oncologist, a specialist in cancers, and they'll say, okay, well, for this kind of a cancer, we're going to put you on chemotherapy. Well, we all know that chemotherapy is poison, and it's designed to poison the tumor cells and kill them, but obviously it's going to poison a lot of other good stuff at the same time. And that decision to use that chemotherapy drug is not specific to that patient. It's just because, well, okay, you have ovarian cancer, or you have breast cancer, or you have prostate cancer. We're going to give you this kind of drug because that's been tried. But the reality is, two people who come in one after one another, they might both have breast cancer, but their breast cancers might act in totally different ways. They might respond, one might respond to this drug and one might respond to another drug. So as we understand the true genetic lockings behind all of these things, we're going to be much more decisive in terms of being able to provide the treatments that are very specific for that person. So medicine is going to become much more individualized, as we move forward. This is probably all going to happen within the next decade. And a lot of the standard treatments that we see now, may just go away as we develop specific, gene therapies and things like that. So I think that's probably one of the most exciting things as we move forward, not just in surgery, but in all of medicine that we're going to be seeing.
This whole robotic surgery thing intrigues me. How much of your surgery is robotic?
Well, we don't have a robot, and Chris, I do most of my work in Tuolumne County, but there's no robot in Calaveras County. So the robots are very expensive, and so therefore you need a lot of surgeons to be using them to make it worthwhile for a hospital to spend $2 million to have a robot that's sitting there and is going to get used once a week. I mean, obviously that makes no sense. So most of the robots are in the bigger centers where they're being used on a more regular basis, and that allows, of course, it's a two-way street. If you don't have a robot, you can't encourage younger doctors, a lot of them who are being trained in robotic surgery, to come in and work in your place, because they're going to say, well, how am I going to do my surgery? I don't know how to pick up a scalpel and make a hole anymore. I mean that's a lost art almost in the future. And so, but you have to have a certain amount of numbers of not just the patients are there, so you have to have a certain number of physicians who are trained in doing that. So not my generation. I just came really right at the beginning of what we call laparoscopic surgery, which is doing things from the outside with these long instruments, which is kind of awkward, and you can get a lot of good things done, but not to the same extent as robotic surgery. But the newer generation of surgeons who are coming out now and trained are pretty much going to demand that. But it depends on, how much can can Mark Twain really afford to spend $2 million to get a robot when, then they're going to have to recruit and do all those things. So that may come in the future, and that would be the hope, because it's much better for the patients, in terms of surgery, if you have an experienced surgeon, because it's not the robot that does the work. It's the robotic hands that are inside you. It's the surgeon that's doing the work. So,
is there a backup surgeon in the operating room in case something would happen, or is the patient just alone with the robot and you're working away in some control room?
There's an assistant. It may be a surgeon, but there's usually an assistant. Oftentimes it's a PA, a physician's assistant, who's trained how to put trocars or these instruments into the patient and monitor things and assist the robot in terms of changing out instruments in the hands. But no, there's usually not, unless it's a very complex surgery, there's usually not two surgeons in the operating room at the same time, just one guy at the console.
Interesting.
Yeah.
Now, what can we do to improve our chances of not getting prostate cancer or urinary infections or whatever? What kind of lifestyle should we be living, and food and that sort of thing?
Well, absolutely. So it's a great question. I think people are really interested in that, because those are things that we feel we have some control over. The diet, our exercise, our stress, our sleep patterns. For the most part, most of us have some control over some of those issues. So just to go through those, in general, obviously diet. Unfortunately, in North America, a lot of us don't have a particularly great diet. We're drinking, a lot of alcohol, or drinking a lot of sodas and high-fat foods and fast foods and, those sorts of things. Those aren't particularly nutritious, and they're hard on the body to digest, and they give us a lot of extra sugars. So we really talk about, in general, and of course if someone's a diabetic, they're going to have to be on a strict diet, but in general, what we call a Mediterranean diet is probably the best. So that's a lot of fresh fruits, fresh vegetables in particular, with your meals, and not massive amounts of meats and things like that. Lots of fish, if you can get it, fresh fish and things like that. So a really wide variety of grains and vegetables and meats, and not just the steak and potatoes guy, and not just the pure vegetarian guy either. Somewhere in between. That's probably the classic kind of a diet that we probably would all strive for. That would be probably the healthiest for us.
Is exercise important in this
And
sort of
exercise
thing?
is of utmost importance. And it's not just important for burning off the calories that we take in so that we don't get overweight. Because unfortunately, as you're probably aware, obesity is just a massive problem in our society. And it's more of a problem, unfortunately, in rural societies.
And why do you think that?
And I think it's because in rural societies, sometimes there's a lower socioeconomic class, so maybe having access to higher levels of foods and things like that may not be as accessible. I mean, it's easier to buy a bag of chips than it is to, maybe buy fresh vegetables and things like that. That may be part of it. Certainly there's a lot of people who are, if you typically think of the hardworking rancher, he's out there from morning till dusk and looking after the animals and putting up new fences. And usually they come into the office and they got their cowboy boots on and their hat. And those guys aren't overweight because they're working all day long.
Right.
And they don't have time to sit down and sit in front of the TV and drink their sodas and things like that.
So many people work in front of the computer.
Well, there you go. So our whole society, of course, has gotten away from the agrarian existence that we used to have, where all of us used to chip in on the family farm and make sure your family had the food. And it was only a very few select individuals who, were sitting in office or a bank manager or whatever and weren't doing necessarily the physical work that the workers were doing. And of course, society has all changed. And now since and Trump talks about, let's bring back industry and things like that, which would be great. We have to have jobs that people can do physical labor. If we're all just sitting there and the only physical labor we're doing is, burning off calories with our fingers and our eyeballs, that doesn't cut it. Then we're going to have to be on massively strict diets. And if you go to any restaurant in the world, I can guarantee that the biggest serving you're going to get is in this country.
Oh, I see. Yeah.
And so we have to retrain all of society, from when we're in kindergarten throughout, that, okay, if we now have a society where we're sitting on our butts all day and not doing physical labor, then either we're going to have some breaks where we go to the gym and we're forcing our kids to, spend the next hour running around the track or whatever it is. We have to get that exercise involved there, but we also have to retrain ourselves in terms of how we're going to eat. Because eating the way we did, in the 1950s, and bringing that now where more and more people are sitting around, obviously doesn't work.
Now, what would you like to learn more of in urology in the future? How would you like to focus?
Well, I guess. I mean, if you're asking me if I could come back. I'm 60 now.
Or improve.
Improve. But if I was in the future now, looking back, let's say 25 years from now, maybe I'll still be alive, but I probably won't still be in practice. It will be very interesting to see, where is the practice of urology? How much of the field is actually still being done by urologists? How much of the field is being taken over by what we would classify as physician extenders? So we have this whole breed of nurse practitioners and physician assistants because they just can't train enough doctors and it's probably too expensive for the system. So how much of patient care is actually going to be taken care of not actually by surgeons or doctors? And how much more in the future, I think physicians are going to be very specialized. So, I'm in general practice. So that means I see patients who come in with general urology problems and, I see them, I do surgery on them, I do all those things. In the future, I don't think we're going to have that. I think you'll have a problem. You'll probably have some kind of a robotic computer system that will be your first ticket. It will check your blood and your urine. It'll spew out some kind of, a series of possible diagnoses. It'll decide whether you even need to spend time with a human or not, or whether it can just educate you, through some other means. And eventually you might get to see a human if you're lucky. And maybe that'll be a person who actually puts hands on you, maybe not. And you'll go through this process, and eventually if you get to a surgeon, you've probably gone through a long sort of tedious process before someone figures that your problem is bad enough that you actually need to see a very highly specialized trained person who may only be doing surgery on the left kidney. We're going to get to the point where we're that specialized, and I see it coming.
Well, Dr. Freedman, we've learned an awful lot today, and we appreciate all the information.
Oh, you're very welcome.
I'm Sid Marsh, and we'll see you next time.